I am Dr. Sharda Jain. Welcome to our YouTube channel, Life Care Center, Sahi Upchar. Today, I'm going to talk about anemia and pregnancy, mainly focusing on the causes and the diagnosis. According to WHO, anemia during pregnancy is defined as hemoglobin less than 11 gram percent. When a woman is not pregnant, the cutoff is 12 gram percent. Diverse definition of anemia during pregnancy are present, but we should stick to WHO classification. Additionally, the anemia during pregnancy can be classified according to the severity of the condition as mild, moderate, and severe, and very severe. As per epidemiological data, 30% of the reproductive age women are anemic, and 40% of the pregnant women around the world are anemic. But as far as our country is concerned, we find that nearly 60 to 70% of the women during pregnancy are anemic. The risk factors for anemia include demographic data, social, physical factors, but mainly the dietary factors. Depending upon the etiology and morphological causes, anemia can be classified into various types, and this particular graph shows what are the different causes of anemia during pregnancy. The commonest cause being iron deficiency anemia as far as our country is concerned. The figure 2 provides how hemodilution is responsible for the hemoglobin concentration and hematocrit to fall, giving rise to physiological anemia. How does it affect the pregnancy? Woman becomes susceptible to infection and preterm labor. These are the main adverse effects of anemia during pregnancy. During labor, she lands up into uterine inertia and dysfunctional labor and cardiac failure. She poorly withstands even a smallest blood loss at delivery. During the postpartum period, she is more prone to sepsis. There's a failure of lactation, and in case if the anemia is severe, she is prone to cardiac failure. It affects the neonates and the fetus. They are low birth weight. And as I told you, the prematurity is one of the main causes. As far as the growth retardation is concerned, it is seen in 3 times more during pregnancy in anemic patients. Now, how do we diagnose? The simplest way to do is to get the CBC test done. We find the main assessment criteria are hemoglobin and PCV. We get peripheral blood smear done, which gives a great clue what kind of anemia are we seeing. Through red cell indices, MCV is important. If MCV is low, then it is iron deficiency anemia. If MCV is high, it is megaloblastic anemia. The causes are folate and a vitamin B12 deficiency. And if it is a normal volume, then in that particular case, it is related to various renal diseases. Also, the indices which are important are MCH fall and MCHC fall. These are very sensitive index. RWD rise is normal in thalassemia. Serum ferritin level, if it is less than 50 microgram per deciliter, it suggests that the stores of iron are depleted. Increase in free erythrocyte protoporphyrin helps in differentiating anemia from thalassemia, and the treatment is rather simple. We need to deworm them after 12 weeks. Dietary explanation is very important. What are the rich sources of iron in the diet, especially emphasizing on the green leafy vegetables? And then she has to be told about the various sources, cheap sources of proteins which are available. She must be told about soya bean, sprouts, dals. Once she has a little information about it and she knows that the IQ of the child is affected by the hemoglobin level of the pregnant patient, she takes all efforts to see to it that the hemoglobin level reaches above 11 gram percent. So it is very important to remember that we get obsessed about anemia in pregnancy as far as the Indian women are concerned, and she should be also told that her hemoglobin status is related to the IQ of the child. Then you'll find it is a win-win situation both by doctors as well as by the patient, and she will work very hard to improve as far as the anemia is concerned.